Hello everyone. So we'll study the topic diseases of pericardium. Right? So we know what are the structures of heart. The innermost structure is endocardium. Then outer that is myocardium, and outer to that is epicardium. So this is the innermost layer. Myocardium is the muscle part of your heart. Epicardium. What is epicardium? Epicardium is part of your pericardium. The topic we are discussing, pericardium. Epicardium is part of that. So epicardium is the so before I discuss your epicardium, let me tell you pericardium has two layers. Then it will be easy to understand what is epicardium. So pericardium has two layers. Okay, fibrous layer, which is the outer layer, and serous layer, which is the inner layer. It has two layers. Pericardium has two layers. Outer layer is fibrous, inner layer is serous. Then serous layer has two layer. One of the layer is epicardium and other layer is parietal layer. So serous layer is divided into two layers. First of all, the visceral layer. The visceral layer means the layer which covers the heart. Let's suppose this is the heart. So suppose this is the myocardium. This part which I'm drawing, this one is your myocardium. This one is your myocardium. So immediately adhered to the myocardium is the epicardium. This red line. What is epicardium? Epicardium is the serous layer of pericardium. Actually not serous, it is the visceral layer of the serous. It is the visceral layer of serous pericardium. Because pericardium, we have two layers. The outer layer is the tough fibrous layer, the inner layer is the serous layer, and in that serous layer we have two layers, one again inner and outer. The inner serous layer is known as epicardium because it is the visceral layer. Visceral means that is inner. And then we have the parietal layer of the serous pericardium. Parietal layer of the, so outside of the visceral layer of serous pericardium. So I'll write it again. Serous pericardium. We have two pericardium. The outer one is fibrous, the inner one is serous. The serous pericardium has inner part and outer part. The inner part is attached to the myocardium, which is the visceral layer of serous pericardium, which is known as epicardium, and the outer layer of serous pericardium, which is known as the parietal layer of serous pericardium. So you can say we have endocardium, myocardium, visceral layer of serous pericardium, parietal layer of serous pericardium. Okay, I'll write P for pericardium. So we have parietal. First we have endocardium. First we have endo, myo, visceral layer of serous pericardium, parietal layer of serous pericardium. Then outside the parietal layer of serous pericardium, we have a space within which we have the pericardial fluid. So the space which is present between the serous pericardium and fibrous pericardium, because outside this space we have fibrous pericardium. Total you can see there are 5 layers: endo, myo, visceral layer of serous pericardium, parietal layer of serous pericardium, and fibrous pericardium. And between fibrous pericardium and parietal layer of serous pericardium, we have the pericardial space. Sorry, my bad, I was wrong in this statement. the space is not between the fibrous pericardium and the serous pericardium. The space is between these two, visceral and parietal layer. Between the visceral and parietal, mistakenly मैंने बोल दिया, sorry, visceral and parietal layers of serous pericardium के बीच में होता है the pericardial space. Okay, so between the two layers of the serous pericardium we have the pericardial space, and outside the parietal layer, outside the parietal pericardium we have the fibrous pericardium. Okay, this space contains about 10 to 50 ml of fluid. Normally there is 10 to 50 ml of fluid. Fluid accumulation in this space is known as pericardial effusion. If it is a slow process, if it is a rapid process of fluid accumulation, it is known as cardiac tamponade. Cardiac tamponade. Let us come to pathology. So first we'll discuss pericarditis. Okay, so pericarditis ka we'll study the classification. Number one, based on duration. So based on duration, it can be acute, it can be subacute or chronic. Based on duration, acute is less than 6 weeks, subacute is more than 6 weeks but less than 6 months, and chronic is more than 6 months. Okay, less than 6 weeks, 6 weeks to 6 months. Chronic is more than 6 months duration. This pericarditis, whatever may be the duration, you will undergo for pathology. See why this pericarditis is there at the first place. So when you see the pathology, on the basis of pathology, it can be dry pericarditis, it can be a serous pericarditis, and the fluid can be serous or the fluid can be when purulent. So purulent, Purulent, purulent or suppurative, that is the term for purulent or suppurative, means pus. Then the fluid can be clear fluid. If it is a clear fluid, it is serous. If the fluid is pus, it is purulent or suppurative. If the fluid is blood, it will be called hemorrhagic pericarditis. Okay, if if there is inflammation of the pericarditis which is causing fibrosis, meaning where the pericardium becomes thick and fibrotic, where the pericardium becomes thick and fibrotic, this is known as constrictive pericarditis. Okay, so dry pericarditis, serous, purulent, hemorrhagic, depending on the fluid. Clear fluid, serous; pus, purulent; blood, hemorrhagic. And if it is a long-term pericarditis which is causing thickening and fibrosis of the pericardium, it is known as constrictive pericarditis. Most commonest type is dry pericarditis. So let us discuss the most commonest type of pericarditis, that is known as dry pericarditis, also known as fibrinous pericarditis. So most commonest pericarditis is fibrinous or dry pericarditis, in which you will hear this MCQ question. Okay, MCQ question, which is, in this we see bread and butter appearance. So bread and butter appearance is seen in case of dry or the fibrinous pericarditis, which is the commonest type. Now why it is called butter? Butter, how butter looks? It looks yellow. So if you see the pericardium outside, from outside, so grossly when you see the pericardium, it has a very rough surface. The surface becomes rough and there are yellow, okay, from there the butter thing comes, yellow exudates. There are yellow exudates on the surface. So that is why bread and butter. Bread is that non-yellow area, the areas which are not appearing yellow, the areas which are rough. The areas which are rough is the bread part, and the areas which have yellow exudate is the butter part. So suppose this is the surface of the pericardium, we are looking from outside. Areas of yellow and the remaining area is rough. Remaining area is rough. This rough area is the bread part, and the yellowish areas, which is due to fibrinous exudate. These yellowish areas are due to fibrinous exudate. Exudation हो रहा है, exudation is taking place. So these yellow areas are due to fibrinous exudate. That is why it is the bread part, and this is the butter part. That is what is known as bread and butter appearance of pericarditis. Fibrinous pericarditis, because histologically you will find fibrin deposition. So when you see the histology, you will find fibrin deposition. So you know how it looks in a gross appearance, how it looks in a microscopic appearance. Also, along with fibrin deposition, you will obviously see inflammatory infiltration of cells like neutrophils, lymphocytes. They will all come inflammatory. Sorry for the poor handwriting. Inflammatory infiltrate. You can also make notes of it. Okay. Inflammatory infiltrate. Okay. There is minimal fluid accumulation. That is why it is known as dry. Okay. Because of minimal fluid accumulation, it is known as dry. And fibrinous because of the histology. And the gross appearance is bread and butter appearance. Okay. Now, what is the most commonest cause of the fibrinous pericarditis? See, the most commonest type of pericarditis is the dry or fibrinous pericarditis, but the most common cause of the most common type of pericarditis, okay, you understand what I'm saying? Most common cause of the most common type of pericarditis, what is the answer? It is uremia. So most common cause of the fibrinous pericarditis is uremia. Remember, uremia. This happens in CKD. And any of the pericarditis, they all can progress to become constrictive pericarditis. So even fibrinous pericarditis, serous pericarditis, purulent pericarditis, hemorrhagic pericarditis, all the pericarditis we discussed, they all, dry, serous, purulent, hemorrhagic, they all can progress and become constrictive pericarditis because it's a result of chronic inflammation. So let us discuss about constrictive pericarditis. Let us discuss about constrictive pericarditis. So constrictive pericarditis is a result of chronic inflammation. It is a result of chronic inflammation which leads to fibrosis, because fibrosis can only happen after a chronic inflammation. Fibrosis, thickening, and sometimes even calcification of the pericardium. So chronic inflammation which is causing fibrosis, thickening, and sometimes calcification of the pericardium. Because of this, the pericardium becomes non-compliant. Okay, the pericardium becomes non-compliant and pericardium is now very stiff. Because the pericardium is very stiff, it does not allow the ventricles to expand. So constrictive pericarditis will result in decreased diastolic filling, because during diastole the ventricles will not be able to expand due to the constriction which is imposed by the pericardium. Pericardium is the cover, the ventricle will not be able to expand, so filling will not happen. So it will cause a kind of a diastolic heart failure like picture. Here you will heard the term Kussmaul sign. What is Kussmaul sign? So we normally understand that the jugular vein pressure will decrease with inspiration. With inspiration, the JVP should decrease. Why? Because with inspiration there is increase in the venous return to heart. When you inspire, lot of blood comes from the periphery to the right atrium. Increased venous return during inspiration. Why? because the thoracic cage is expanding. Inspiration causes expansion of your thoracic cage. So the heart has more area to expand, and it creates a negative pressure also in the thoracic cavity, because when the pressure is when the volume is more, the pressure decreases, right? When the volume is more, the pressure decreases. So here the volume is more, the space has become more, so the pressure in the heart is now less. Right atrium, the pressure is less, so the blood will get back to the right atrium. Understand my point? Inspiration, we are increasing the volume. First thing, expansion. During what happens during inspiration? During inspiration there is expansion. Expansion decreases the pressure in the right atrium. This decrease in the pressure in the right atrium causes increase venous return. Increased venous return will decrease the jugular venous pressure. Okay? It will decrease pressure in all the peripheral veins also. So first point is expansion. With expansion there is increase in the volume. With increase in the volume there is decrease in the pressure. Decrease pressure, so from high pressure to low pressure blood will flow, so there will be more venous return, because now it is a low pressure area. Blood will come back and jugular venous pressure should go down. In Kussmaul sign this does not happen. In Kussmaul sign, with inspiration the JVP do not fall, or it may even lead to rise of JVP. So normally we say do not fall the JVP. So the JVP do not fall, or it may even paradoxically rise. So the jugular vein pressure do not fall, or it paradoxically rises. So this is known as Kussmaul sign. Because obviously you understand, in constrictive pericarditis, even though there is expansion which decreases pressure, but this pressure decrease is only limited to thoracic cavity. The right atrium, which is the receiving chamber, does not expand, because it cannot expand, because the pericardium is not allowing it to expand, because the pericardium is thick, fibrotic, and it may be even calcified. So no decrease in the pressure, so no venous return. JVP do not fall. JVP do not fall. This is Kussmaul sign. Kussmaul sign means impaired filling of right ventricle. Obviously right atrium will fill, then passively right ventricle will get filled. So impaired filling of the right ventricle. This Kussmaul sign is not exclusive to CP, yani constrictive pericarditis. It is not limited to constrictive pericarditis. It is also in case of right ventricle infarction. Even in right ventricle infarction, the right ventricle will not be able to expand. So again, JVP will not fall. Other than, so it can be problem of the pericardium, or it can be a problem of the myocardium, like RV infarction, or it may be a problem of the other sort of problem of the myocardium, like it's a restrictive cardiomyopathy. Restrictive cardiomyopathy, I'll write in short CMP, cardiomyopathy. So it is either the problem of the pericardium or the problem of the myocardium, like RV infarction or restrictive cardiomyopathy. Okay, or it may be problem of the valve, like tricuspid stenosis, because of which blood is not going from right atrium to right ventricle. So everything is limited to right atrium, but right atrium cannot receive that much amount of blood. The blood has to also be received by right ventricle. So pericardium problem, myocardium problem, two problem of the myocardium, RV infarction or restrictive cardiomyopathy of the heart, and tricuspid stenosis. And rarely even in cardiac tamponade also, because cardiac tamponade also does not allow the heart to expand because of the fluid that is accumulated, but not pericardial effusion. Cardiac tamponade can cause. So pericarditis, cardiac tamponade, RV infarction, restrictive cardiomyopathy, tricuspid stenosis, they are all possible cause of your Kussmaul sign. Just to give you an idea, we have two Kussmaul. We have the Kussmaul sign, which is failure of the JVP to fall, and we have Kussmaul breathing. Okay, Kussmaul breathing is deep breathing and rapid. This sort of breathing, rapid and deep breathing, rapid and deep breathing, and it's a labored breathing. Rapid, deep, and labored. Three words are there: rapid, deep, and labored breathing. Okay, this is seen in any condition of metabolic acidosis, because to decrease the acidotic state, your lungs are trying to wash out the CO2. So CO2 washout is the compensatory mechanism to reduce the acidotic state. Acidosis, you have metabolic acidosis. How do you compensate? Metabolic acidosis, you will compensate by respiratory system. If you have respiratory acidosis, you will compensate by the metabolic system. So metabolic acidosis patients will try to wash out their CO2, and this is the way, by Kussmaul breathing. By washing out CO2, your pH increases, so you compensate against the acidosis by washing out the CO2 with Kussmaul breathing. But now I'll just tell you, Kussmaul is a person who is actually a German physician. Just very little information I'll give you. He is a German physician and his name is Adolf. So Adolf से ही आपको समझ में आ रहा है, obviously German guy. So Adolf Kussmaul, a German physician of 19th century, Adolf Kussmaul, he gave these two signs. Let me ask you a question. Okay, so tell me which of the following is not a feature of constrictive pericarditis. Okay, you will hear the question. Which of the following is not feature of constrictive pericarditis? Let me give you options. Kussmaul sign, I have already explained you what is Kussmaul sign, and the question is which of the following is not feature of constrictive pericarditis. Second, pericardial knock, Pulsus, paradoxus, option D, ascites. So tell me which of the following is not a feature of constrictive pericarditis. Okay, so before I go to that, I should tell you what is pericardial knock and what is Pulsus paradoxus. So pericardial knock is a sound between S2 and S3. Sometimes people confuse it with S3, but it is a sound which is just after S2. Pericardial knock S2 के just after होता है. It is just after S2. Just let me tell you about the heart sounds. You know what is S1? So S1 is the closure of mitral and the tricuspid valve, right? So mitral valve and tricuspid valve, when they close, it is S1. What is S2? S2 is the closure of the aortic and pulmonary valves. Okay, so जो ऊपर वाले valves है, mitral and tricuspid, when they close, you get S1. When the atrial and pulmonary valves close, the aortic and pulmonary valves close, it is going to give you S2. When does S1 happen? It is the just before systole. So just systole is about to happen. The heart is the right ventricle and the left ventricle, they are filled. Again listen, the right and the left ventricle, they are filled, and now the mitral and tricuspid valve close. So already the blood was coming to the right and left ventricle, and the aortic and the pulmonary valves are closed. The heart is getting filled with blood, and now immediately the mitral and tricuspid valve close. The moment they close, now already previously aortic and pulmonary valves were closed. Now mitral and tricuspid valves, they also close, and now the heart will contract. So just before the systole, the mitral and tricuspid valve close. So the closure of the mitral and tricuspid valve means the heart is now about to contract, systole. Okay, so beginning of systole is S1. S2 is the closure of the aortic and the pulmonary valves. So this is the beginning of diastole. So before that, the the aortic and pulmonary valves were open. So aortic and pulmonary valves were open. Okay, from there blood was going to the pulmonary artery and the aorta. Now, the moment the aortic and the pulmonary valves close, which is the S2 sound, it means it is the beginning of diastole. So this was your right ventricle, and this was the outlet. Suppose pulmonary trunk. This is right ventricle. Blood was going out from it. Now, what happened? S2 happened. This point got closed. So pulmonary valve closed. So pulmonary valves are now closed. So this is the beginning of diastole. Now this is open. So now blood will get inside and will get filled. Okay. This is the tricuspid valve. Okay. So before the closure of the aortic and pulmonary valves, they were closed. They were open. So blood was going out into the outlet. There is aorta and pulmonary artery. The moment they closed, it is now the beginning of diastole. So S1 means closure of the mitral and tricuspid valve. So this is the beginning of systole. Closure of the S2, so S2 is the closure of the aortic and pulmonary valves, which means the beginning of diastole. This is the beginning of diastole. I know I'm giving you a lot of extra discussions, but I want you to understand the concepts very clearly. And how do you listen it? I'll write it. Love, dub, S1, S2. You see how I have written it? Love, dub. So dub is big. So it is low pitched. Love is low pitched. Dub is high pitched. So he will hear the S2 more louder. Okay. But this higher pitched is of shorter duration. So although it is high pitched, but it is shorter duration. And it is low pitched, but it is of longer duration. It is longer than S2. That is why you can hear S1, because it is low pitched. Suppose if it was also shorter, तो आपको सुनाई नहीं देता. You couldn't have heard it, right? Suppose I'm just giving a concept. It is low pitched plus it is also short duration. How you would have heard it? So although it is low pitched, but it is longer, so that is why you can hear it. And this is high pitched, so obviously you can hear it, but it is of shorter duration. So that means from S1 to S2, you have systole. So blood is now getting so the heart is contracting, and just before S2, the aortic and pulmonary valves open and the blood goes out into the aorta and pulmonary trunk. So between S1 to S2 is the systole, and just before S2, your aorta and pulmonary valve open. Sorry, the aortic and pulmonary valves opened and the blood rushed out. And with S2, these aortic and pulmonary valves close. So now from S2, you have diastole. Now these extra additional sounds, S3 and S4, are sounds of diastole. So S1 to S2, you have systole, then S3, then S4, and then again S1. So this part is from S2 to S1 is diastole. So S1 to S2, then again S1. This is systole, this is diastole, and within diastole you hear S3. So this is just after S2. Just after S2 is S3, and just before S1 is S4. So if you see S2 and S1, it is like this: S3, S4. So just after S2 you have S3, just before S1 you have S4. So you can say S3 is early diastole and S4 is late diastole. This is clear. So what the pericardial knock is, it is immediately heard just after S2 and it appears like S3. Which one? Pericardial knock. Let me tell you, S3 is normally heard, okay? It is normally heard in people who are children and young adults. So children and young adults, you will normally hear S3. But in an adult person, suppose who is aged above 40, you will not hear S3, because S3 is heard due to the filling, rapid filling. So S2, what happened in S2? The pulmonary valve and aortic valve closed, so it is the beginning of diastole, and all the blood now jumped from atrium to the ventricle. So this rapid filling will cause vibration of the myocardium and will give you the S3 sound. And this is normal in a child or a young adult, but not for someone who is more than 40 years of age. In this person, S3 is not normal. In a person who is more than 40 years of age, if you are getting S3, what does that mean? It is meaning volume overload, because it's a diastolic sound and it's a sound of filling. And if you are getting a sound of filling, that means there is a lot of filling going in. That means it's a volume overload state. That means it's a volume overload state. That means it is a heart failure. Heart failure, there is a volume overload. Okay, volume overload state. Or if it is not a heart failure state, suppose it's a regurgitation state like mitral or aortic. Because of regurgitation, a lot of blood now went back from the aorta back to the left ventricle, or due to mitral regurgitation, the blood came back from the right atrium to right ventricle. Sorry, mitral regurgitation. What happened in mitral regurgitation? So left ventricle and left atrium, and this is aorta. So in aortic regurgitation, blood went back from the aorta to the left ventricle. So now it's a volume overload. In mitral regurgitation, the blood went back from left ventricle to left atria, and this excess blood will again come back to left ventricle. So this is again volume overload. So both aortic regurgitation and mitral regurgitation, which is a regurgitation. So suppose left atrium, which is separated by this line, that is mitral valve. Then we have left atrium. Then we have the aortic valve, and then we have the aorta. So regurgitation, so LV, aortic regurgitation, mitral regurgitation. These two or heart failure will give you volume overload, that is will give you S3 heart sound. How will you differentiate S3 from pericardial knock? So S2, then pericardial knock, then S3, then S4, and then S1. So it is before S3. But can you differentiate it? Absolutely not. Patient is 40 years above, he should not have S3. So anyway, you will not hear S3. So if you hear pericardial knock, you will feel like it is an S3. Okay. So very difficult to say ki pericardial knock is just before S3, but not possible, brother. You cannot differentiate it like this. So how can you differentiate? It is the sound quality. The quality of sound between S3 and PK is different. Okay. So the quality of sound is different. Pericardial knock, the sound is high pitch. So it's a knock. Okay, tuck, tuck. So it's a knock. High pitched, sharp knock sound is pericardial knock. But S3, it says the S3 is a soft sound. It's a soft, low pitched sound. And that is how we differentiate. It is not an S3, it's a pericardial knock. So pericardial knock is a high pitched early diastolic sound heard just after S2, and it is associated with pericardial condition. That is what is known as pericardial knock. So obviously it is seen in constrictive pericarditis. So in constrictive pericarditis, you will find both Kussmaul sign as well as pericardial knock. Why this sound is heard? Because of the sudden cessation of ventricular filling. Filling is not happening. Sudden cessation of the ventricular filling due to the non-compliant rigid pericardium. There is sudden cessation of ventricular filling, which gives this S3 sound, which gives this sound, pericardial knock. The third option, Pulsus paradoxus. So Pulsus paradoxus is a condition where there is a drop in the systolic blood pressure of more than 10 millimeter mercury during inspiration. So this is definition of Pulsus paradoxus, that is your systolic blood pressure drops more than at least this value. So first point is systolic blood pressure, second point is the drop, that is more than 10, and third point is during inspiration. So what is falling, how much is falling, and when it is falling. When it is falling during inspiration, how much is falling, more than 10, what is falling, SBP. So normally it falls during inspiration, the BP falls because the inspiration causes expansion of the right atrium, expansion of the right ventricle, as well as expansion of the pulmonary arteries. Pulmonary vessels also expand, pulmonary artery expands. So right atrium expands, more blood is received, right ventricle is also expand, from the right atrium more blood is received, and pulmonary artery also expand, more blood is received from the right ventricle. Because the pulmonary arteries expand, so right atrium, right ventricle, and pulmonary artery together, these three are holding now a lot of blood. They're holding a lot of blood. So from pulmonary artery, now the next point is left atrium. But what happens during inspiration? Now blood is not going from pulmonary artery to left atrium. Matlab, blood is going, but less blood is going from pulmonary artery to left atrium, because pulmonary artery is now also holding blood. RA, RV, pulmonary artery, they're all holding blood. Less amount of blood is going from pulmonary artery to left atrium. So left atrium to left ventricle, again blood volume is now reduced. So aorta, the blood output is reduced. So you get a decrease in the systolic blood pressure. So clear understanding of the decrease in the blood pressure during inspiration. Okay. In this condition, Pulsus paradoxus, this decrease is more than 10 millimeter of mercury. Now, as per your understanding, why it should happen, why the systolic blood pressure should decrease more than 10 millimeter of mercury, is a condition when the heart is not able to get filled. It is a condition where there is impaired filling of left ventricle. Left ventricle is not getting filled. So anyway, it is getting less blood. Okay, it is getting less blood. But if there is a condition where the left ventricle is not able to get blood more than what it should, normally it should decrease. Okay, normally the blood coming from the left atrium to left ventricle is decreased during inspiration. Okay, accepted. It is accepted that yes, during inspiration the blood is coming less from left atrium to left ventricle. The blood that is coming from left atrium to left ventricle is less during inspiration. But why the drop is more than 10? Because the blood that is supposed to decrease the flow from left atrium to left ventricle, the flow that should decrease, it is decreasing more. That means the flow from left atrium to left ventricle is decreased drastically. Now this should happen only in conditions when the left ventricle is not able to expand. When the LV filling is not happening, the LV is not able to expand. That is when the systolic blood pressure should decrease more than the normal. It should decrease, but not decrease more than 10 millimeter of mercury. This is only possible when the left ventricle is not able to expand. Now, of your concept and understanding, it should happen in constrictive pericarditis. It should happen because in constrictive pericarditis, yes, the left ventricle is not able to expand, the right ventricle is not able to expand, the right atrium is not able to expand, the right atrium, right ventricle, left atrium, left ventricle, both atrium, both ventricle, they are not able to expand. So LV is not able to expand. If the LV is not able to expand, then yes, so LV filling is decreased. So LV filling is decreased. If LV filling is decreased, then what should happen? If LV filling is decreased, then the LV output should also decrease. If the LV output decreases, then the systolic blood pressure should decrease. But that is not the case. Why? There is something called ventricular interdependence. See, in constrictive pericarditis, both ventricles cannot expand. So what the ventricles does, they talk to each other. Right ventricle and left ventricle, they talk to each other, says, hey bro, we are not able to expand because of this bloody pericardium. Let us decide and plan. If I expand, you don't expand. If you expand, I will not expand. So there is talking between ventricles. When one ventricle fill more than the other one fill less. This is interdependence. They are talking with each other. Ventricles are talking to each other. When one ventricle fill more, then the other one fill less. So during the time of inspiration, sorry, I got disturbed with a phone call. So I was telling you that there is a ventricular interdependency. Okay, one ventricle will fill more than the other one. So in this condition of constrictive pericarditis, left ventricle will fill more than RV. As a result, LV output will not decrease. As a result, systolic blood pressure will not decrease. So LV is filling more than RV. So LV filling, if LV is filling, then the LV output is also maintained. So systolic blood pressure is also maintained. As a result, the drop in the systolic blood pressure is not more than 10. So there is no pulsus paradoxus in case of constrictive pericarditis. So why it does not fall? It is because of the ventricular interdependence. So remember this, in constrictive pericarditis, you have two important signs. Kussmaul sign, pericardial knock, but not pulsus paradoxus. This is seen in cardiac tamponade, CT, cardiac tamponade. Cardiac tamponade, there is no ventricular interdependency. That means the right ventricle is not talking to left ventricle. Why? Because to develop ventricular interdependency, I'll write in short, VI, to develop ventricular interdependency, it takes time. Right ventricle will talk to left ventricle. So this talking will happen only after certain time. But in cardiac tamponade, it is acute. It is acute. There is acute accumulation of fluid in the pericardial space. So because of this acute accumulation, there is no time at all. So ventricles don't get the time to develop this talking habit with each other. So there is no development of ventricular interdependency because of the acute nature of that disease. Because constrictive pericarditis is a chronic condition. So because of this, ventricle starts to talk to each other. But in acute conditions, they don't get the time to develop this technique of ventricular interdependency. So as a result, both right ventricle and left ventricle, they are compressed equally. As a result, ventricular filling is affected. So you see pulsus paradoxus in case of cardiac tamponade. I hope you get this concept. Read, listen it again if you don't get it. If you know what are the other things you find in case of pulsus paradoxus, okay, sorry, cardiac tamponade. Cardiac tamponade, you know, you have this thing called Beck triad, BECK TRIAD, Beck's triad. That is hypotension. Why? Because of the compression of the LV. Systolic blood pressure decreases. Hypotension, muffled heart sounds because of the compression and the fluid that is around it. Because of the fluid that is surrounding it, the sound waves that are transmitted, they are transmitted less. So hypotension, muffled heart sound, and jugular vein distension. Okay, these are the features: hypotension, muffled heart sound, jugular vein distension. These three are together known as Beck's triad. Hypotension, muffled heart sound, jugular vein distension. Hypotension, muffled heart sound, jugular vein distension. What do you see? Pulsus, paradoxus. What do you don't see? Kussmaul sign. Kussmaul sign and pericardial knock with constrictive pericarditis. Pulsus, paradoxus with cardiac tamponade. Now, why you don't see Kussmaul sign in cardiac tamponade? You can see, but you see less often. And also similarly, in JVP also, in constrictive pericarditis also, you can see pulsus, paradoxus, but again, these are like more commonly associated with these conditions. Pulsus, paradoxus more common with cardiac tamponade. Kussmaul sign and pericardial knock more common with constrictive pericarditis. So answer will be, which is not seen with constrictive pericarditis. Answer is pulsus, paradoxus. Ascites obviously you can have because of the venous stasis. That is, blood is not accumulating in the it is not going into the right atrium. So right atrium में अगर blood नहीं जाएगा, if the blood is not going to right atrium, then it will accumulate in the SVC, IVC, and it will increase the portal vein pressure, splanchnic vasodilatation, fluid will leak, resulting into ascites. We'll discuss the remaining part of the diseases of pericardium in the next lecture.